I never get to thank him. And it's my really pleasure and honor to introduce Dr. Mubarak AL-Gahtani, who is going to talk about peripheral nerve injuries.
Thank you for this introduction. I would like to thank Professor Ammar and Professor Anizi and also the organizers of this meeting for inviting me to give my humble talk on peripheral nerve injury. I will always use every opportunity to praise me, though Ammar is a star, and thank him for his introduction. To understand peripheral nerve injury, we need to understand some basic anatomy. It's really crucial. You will not be able to treat peripheral nerve in a good way without understanding the topographical anatomy of the peripheral nerve. So a nerve is formed of axons. If the axon has got a myelin sheet around it, and there is a basal lamina around the myelin sheet, a group of axons will form a fascicle that's surrounded by perineurium, and then all these fascicles will be grouped together in a given nerve. There is cross communication between the nerve fascicles, and sometimes there is also anastomosis between different nerves. The nerve is very rich in blood supply. This is why you can immobilize the nerve for a long distance without feeling devascularizing the nerve, because there is rich blood supply from outside the nerve and from within the nerve. So if a nerve is injured, what will happen? There will be formation of a sprouting end at the proximal end of the nerve. So the first thing that will happen, there will be a Wallerian degeneration of the distal stump. There will be also proximal degeneration for a short distance, and then next there will be the sprouting of the nerve. So based on the integrity of the connective tissue, this regenerating unit will reach the distal stump and will grow distally. So if the basal lamina of the nerve, if the perineurium of the nerve is intact, this regeneration will most likely reach the target organ. If there is an injury to the connective tissue, this regenerating unit will get frustrated trying to reach its distal end. So this is why, in fact, the nerve, the distal nerve, act as a scaffold for the regenerating unit. And this is the principle that we use to use other grafts, or sometimes even a vein or a nerve conduit, to guide these axons to reach their target organ. There will be a pruning of these other nerves, and there will be remyelination, and this will be the way the nerve will reach its distal organ and will be renervated. If there is a scar, there will be a neuroma, and this sprouting end will never be able to reach the distal organ. So another example of the median nerve neuroma from injury to the distal forearm. So, what happened during nerve injury? There will be a division of the nerve, Wallerian degeneration of the distal end, and there will be also degeneration of the proximal axon. Now, why this is important to understand? This is why in non-clean, sharp injuries, we wait for some time before intervening, because we would like to allow some time for this, because if a nerve is bluntly injured and you go next day and reapproximate the ends, then during the next few weeks there will be proximal axonal degeneration. So you're actually creating a neuroma in continuity, because you are connecting a degenerating end of a nerve to a distal end. This is why the injury is blunt. We have to wait for some time to allow the longitudinal injury to declare itself. This is followed by sprouting of the distal axon and regenerating unit that is guided by the intact connective tissue to the distal organ. So, based on the length of the gap, the scar, the neuroma, there will be the chance to re-innervate the distal organ. So a large gap or a neuroma or a scarring will prevent this. the surgery is simply to direct these regenerating fibers into the distal organ. So the first thing start by our ability to evaluate the patient with peripheral nerve injury. And despite of advancement in all fields of medicine, this in peripheral nerve surgery remains to be a clinical. And the other ones like investigation or electrophysiological studies, until now, they are only an adjuvant to your clinical ability to localize the lesion, determine the nerve injured, and which, if it's complete injury or incomplete, and which part of the nerve, and where exactly in the nerve is the injury. A key question that a resident or a specialist or anyone who deals with nerve injury need to answer is, first of all, from history, try to understand what is the mechanism of injury. It makes a big deal when we deal with peripheral nerve injury, because based on the mechanism will be the decision. An example, if you have a patient with shoulder injury and there is an axillary nerve injury, then you need to know, is that from a traction or is that from a cut of the nerve? From, for example, a fracture of humerus. And then this makes a difference to the intervention. How severe is the injury? Is it focal injury or diffuse injury? Which nerve elements are injured? And is it lacerated injury or is it a contusion, or is the nerve continuity or severed? Is it complete or incomplete? Some part of the sensory element may be spared, and autonomic function may be spared. These will dictate your decision whether to intervene early or to wait. A nerve which is completely injured is very less likely to spontaneously heal compared to a nerve that's partially injured. A nerve with sensory sparing is likely to spontaneously improve. That's different from a nerve which has no sensory or motor or autonomic function left. I'll give you a famous example. If you have a patient with complete motor deficit, but intact sensory and intact autonomic function, among the resident, what do you think the problem? What is this problem in this patient? You have a patient, no motor function whatsoever after some injury, but there is intact sensation and intact autonomic function. Can you take it? So, if you have this example, it's likely neuropraxia. You should not intervene surgically early. You have to wait. Give time, because a nerve that has intact sensory function but profound motor deficit is most likely a neuropraxic nerve. You give it time, it will heal, and see just your clinical assessment made a big difference in this patient. If you intervene, you converted one of the best injury that will heal spontaneously to another injury that will be surgical injury then. And then finally, you need to assess what is the progression. Is it static, is it improving, or deteriorating? Deterioration in peripheral nerve injury is very rare, but usually result from hematoma, compartment, or pseudoaneurysm, because sometimes there is a combination of vascular as well as nerve injury. Physical examination, adequate exposure is a must. Look at the posture of the limb. Do not overlook the axial muscles. Another example, if you have a patient with brachial plexus injury and you found there is pectoralis major wasting, this is very important information, because pectoralis muscle is supplied by the lateral pectoral nerve, which is from the upper elements of the brachial plexus, and it's also supplied by the medial pectoral nerve, which is supplied by the lower elements of the brachial plexus. If you have wasting pectoralis muscle, it's a bad sign, because it means the whole elements of the brachial plexus are involved. And one piece of information from an axial muscle will give you an idea on the prognosis. In your examination of peripheral nerve, please, you should have a system, either proximal to distal or distal to proximal, but I think the way I would advise you is to start from proximal to distal, your examination of motor units, as well as the sensory and the reflexes. You should compare both sides and contrast them, and you should discriminate between a given movement and a function. A patient with elbow flexion does not mean his musculoskeletal nerve is intact, because he could simply use his brachioradialis, which is supplied by radial nerve, to bend his elbow. So you should discriminate between the muscle action and a movement of a joint. And then be aware of the tricks the patient uses, especially children with Ehlers palsy. They will use all kinds of tricks that you will think the patient is bending his elbow, when in fact he's using his anterior fibers of deltoid to drag his shoulder and so bend his elbow, especially if he's in a supine position. So be aware of the tricks the patient can use in order to overcome his weakness and learn it misleading. In sensory examination, I find it tricky because it's very subjective, but you should focus on the autonomous zones of innervation. There are some zones only supplied by this nerve and no other nerve. For example, the snuff box is only supplied by radial nerve. The tip of the little finger is only supplied by ulnar nerve. So these areas are very specific, and examining them will give you a lot of information. Like if you examine patient in a general way, not aware of the dermatoma distribution or the overlap between the nerves, it will be very confusing sometimes. Sometimes in peripheral nerve injury, some sensory modalities are affected more than others, and you will find a patient with almost an intact touch, but when you examine him for a thermal sense or for pinprick, you find that the deficit is more pristine and more clear to you. Lack of sensory finding does not mean the patient is not completely, the nerve is not completely injured, and that's because of the cross-anastomosis between the nerves and over supply. One thing that is very specific and very, very accurate is the myotactic reflexes. If you find the reflex is absent, that's a good sign. And many times you see patient with brachial plexus injury, or sometimes malingering, or some secondary gain patients, and you examine the reflexes, you find them intact, then you know that there is something here that you need to study further. Tunnel sign is very famous, and advancing tunnel sign is a good sign, but one thing you need to know is that only 50% of those with advancing tunnel sign will improve spontaneously to a functional, meaningful recovery. But lack of tunnel sign is a very important negative finding. The tunnel sign is not advancing, likely the nerve is not progressing in its regeneration, so it's important. And autonomic activity, as I said, the example I gave you, propagative reflexes, tests you can use, for example, Fallon test or pronation test or Allen test to try to help you localize the anatomical location of injury. Pain is very frequent after nerve injury. It could be from several reasons: disuse, entrapment, neuropathic pain, autonomic deafferentation, or sometimes painful neuroma. And sometimes pain alone is an indication for intervention, because external neurology could reduce the local pain, especially if it's a sensory neuroma. Sensory deficit varies from lack of sensation to pain to abnormal sensation. And the evolution of sensory finding is very important. A patient who is regaining sensation is a good sign, and then this will encourage you to wait and not to intervene early. But motor deficit remains the most important thing that you have to elicit in your physical examination. Not only the extent, so the extent and then the relation to a nerve in particular, and also particular nerve element, and furthermore the evolution of the deficit. And then you should understand the importance of this deficit functionally. And an example I'll give you is a child with Ehlers palsy. If you wait on this patient and they start to regain their elbow flexion and shoulder abduction, but usually they don't regain their supination. And now, so there is a deficit, which is lack of supination. But what's the functional environment of the child? And is it important for a child to have a supination if he has regained good shoulder abduction and good elbow flexion? So you have to have this in mind, because this will also dictate your decision whether to intervene the physiotherapist, if you find a good one, it will be a good source for you in helping you examine the patient, as well as taking and making a good decision. Now, in the emergency room, please pay attention to life-threatening injuries in these patients. And 60% of 40% of peripheral nerve injuries are missed in the initial encounter because of either the patient is comatose or because of associated limb injury and pain. But it's common. 55% of peripheral nerve injury incidents in a patient with body trauma and 1% of brachial plexus. So, as a rule, any patient with soft tissue injury, joint injury, bone injury, you should look for, or vascular injury, you should look for associated peripheral nerve injury. And then to make it fast in the emergency room, just look at the most, this is the rule of thumb, look at the muscle that is supplied most distally by that nerve. So instead of going from proximal to distal, just if you want to make sure the radial nerve is working, just go to the muscles most distally supplied by that nerve. If they are intact, then most likely the nerve is intact. Now, your initial exam is very important, and many surgeons, especially orthopedic surgeons, were saved by good neurosurgical residents who documented the foot drop in emergency room post hip dislocation. So it's good, and it's also from medically legal aspect, it's very important. You should try to come out with 2 questions: which nerve injured, where exactly injured, what is the severity of injury, and key question is the completeness of injury. Complete injury are less likely to recover, while partial injuries have a better chance to recover. In peripheral nerve injury, this is a very important thing to understand, which is the different types of injuries, the different classification, and as we discussed before, the nerves are organized. Axons are grouped in fascicles, and these fascicles are surrounded by perineurium, and within is the indoneurum. And based on which of these is injured will be the grade of injury. If it's mainly demyelination, it's a grade 1. If there is axonal injury but basal lamina is intact, it's grade 2. Once you have indoneural injury, it's a grade 3. Once you have the perineural injury, it's a grade 4. And once we say grade 3 or 4, we're talking about connective tissue injury, whether the indoneural or perineal. And once you have connective tissue injury, connective tissue will deal with a scar, and a scar will lead to a frustration of a growing nerve. And so the prognosis will be worse. So I think I will speak through this because most of you know it. But it's just show you this neuropraxia. There's usually disproportionate loss of motor function over sensory, and there is the autonomic function is usually spared, and there's excellent recovery is always the rule. In the axonal injury, there will be distal degeneration and then regeneration, and this famous rule that you know is 1 millimeter per day or 1 inch per month regrowth. This is applicable mostly for the axonal injury, because once you have a scar, then this may not apply. Once you have grade 3 or 4 injury, as I said, there will be a fibrosis, and then this will impair the groin nerve. This could result in a neuroma in continuity because there is the epineurum of the nerve is intact. So on the outside, the nerve is not cut, but inside there will be a lot of scarring, and this will lead to frustration of the growing axons, and this will lead to neuroma in continuity. So what I'm trying to say here, if you saw a nerve that's intact from outside, it does not mean it's intact from inside, and this sometimes, if there is lack of functional improvement, then during surgery there will be a rule for splitting the nerve, dissection of the nerve, and discerning whether the nerve elements inside the nerve are cut or they are neuroma in continuity, because you could do split repair based on the intraoperative finding. I'm trying to be on time. So the the axonal injury, they will always need a repair. And then here, please, I want to make a very clear distinction between sharp injury and blunt injuries. Sharply divided nerve, early intervention is the best chance for the patient, while bluntly injured nerve, it's better to wait for some time. And as we said, the principle behind that is to allow the proximal degeneration to take place and for longitudinal extent of the injury to declare itself. I have another talking case, the time limit, but now I'll give the floor for Dr. Bassam.